Hello friends, welcome back to my channel with a new video, and this is a final and the part 4 of the airway or a difficult airway in ICU series. So let us start with manual inline stabilization or MILS. So this is a technique used during tracheal intubation to protect the cervical spine in patients with suspected or known cervical spine injuries, involving an assistant stabilizing the head and neck to prevent the movement during laryngoscopy and intubation. It naturally protects the cervical spine and it aims to minimize the movement of cervical spine during airway management, which can potentially worsen a spinal cord injury or cause the new one, which is not existing. So, standard of care, which is, it's considered a standard of care for airway management in patients with suspected or known cervical spine injuries. So, how is it performed? So, assistant's role, uh, uh, who performs the MILS or MILS by gently grasping the patient's mastoid processes or cradling the occiput to maintain a neutral position. This is what the assistant's role is. Importantly, there is no traction or no pulling which should be applied on the cervical spine, and the goal is to prevent movement and not to manipulate the spine further. So as you could see that the person who is at the head end of the patient is the actual operator who is going to intubate this patient. As you could see a laryngoscope here, and this is the assistant who is helping the MILS by, as you could see, by uh, stabilizing the mastoid processes. So they are not coming into the way of uh, operator. And uh, here, as you could see, that in A, uh, the mills applied which is incorrect, limiting to the mandibular range of motion, whereas mills in this particular B diagram is correct because the hands are over the ears. So it is also called as ear muff approach, not limiting mandibular range of movements. So the ear should be covered like this and the stabilization is done. So this is the correct way, this is the incorrect way. Now coming to FOI or fiber optic intubation, and advantages are of course the direct visualization. It allows the direct visualization of vocal cords and airway, which is particularly helpful in difficult intubations or when anatomical abnormalities are present. Awake intubation. The patient can be awake because here we are inserting the fiber optic scope through the nostrils and you are railroading the endotracheal tube over the bronchoscope. So it can be performed when the patient is awake, which is beneficially again particularly for the difficult airway or hemodynamic instability or those with the risk of aspiration. And there is reduced stimulation. So awake FOI avoids the stimulation of oropharyngeal structures associated with direct laryngoscopy, potentially leading to less of the hemodynamic instability. There is definite flexibility to the scope which allows the maneuvering around the anatomical obstacles and into the difficult airways. It improves the first pass success, and of course the suction and the secretion management, which is definitely helpful in critical ill patients. So these are various advantages of the fiber optic intubation. Now the other side to the coin is the disadvantages. So number one is it is time consuming. It may not be a quick technique, especially when the operator is not an expert. Number two, the availability of the bronchoscope inside the ICU. It may take some time if the intubation or the bronchoscope is not in the ICU and in the respiratory or pulmonology department. It requires expertise, as I said. There is potential for airway trauma with the improper technique or excessive force which is usually applied during the procedure, which can lead to airway trauma or trauma to the vocal cord and then the bleeding thereupon. And of course, the sedation complications that while awake FOI is preferred, the sedation may be necessary in few patients where over sedation can have problems such as hypoxemia or airway obstruction. Again, as I said, the equipment may not be readily available. There is definite infection risk and the cost, of course. So, if someone utilizes the bronchoscopy services, the cost will definitely go up. Is there any role of POCUS or point of care ultrasound, which is emerged as a promising tool for the airway management due to its familiarity, accessibility, safety, and non invasive nature? It can certainly assist physicians in identifying relevant anatomy of the upper airway with objective measurements of the airway parameters, and it can guide airway interventions with dynamic real time images. To date, ultrasound has been considered highly accurate for one, assessment of the difficult airway, confirmation of proper endotracheal intubation, prediction of post intubation laryngeal edema, and preparation for cricothyroidotomy by identifying the cricothyroid membrane, especially with a longitudinal view or when the probe is kept in a longitudinal plane. So these are the definite kind of advantages or the benefits of POCUS in the airway management. As you could see here, as I said, so this particular cartilage, as you could see that this is a thyroid. This is a longitudinally placed probe on just the midline of the trachea. This is a cricoid, and there is a classically it is identified that there is a dip from the cricoid to the first tracheal ring. So when there is a dip like this has to be a cricoid cartilage. This particular membrane, which is a radio opaque line, is the cricothyroid membrane, and this particular shadow, hypoechoic shadow, which is like a thyroid cartilage. So classically, a cricoid cartilage in the transverse view is seen as a horseshoe shaped structure. So this is the horseshoe shaped cricoid cartilage. So these are the tracheal rings. As I said, when you have a dip from the hypoechoic structure, so there is a dip, and then this is the first tracheal ring, the second tracheal ring, the third. This is the first tracheal ring, second tracheal ring, third and fourth. And so this is the air mucosal interface, as you could see, and these are the reverberation artifacts, which are primarily because of the air inside the trachea. And you can see a double lumen sign, which is again a sign related to the endotracheal tube. So you can actually identify that the endotracheal tube is placed, and there are a lot of air artifacts. They are also called as mirror artifacts, when you could see the same images as you could see here. So these are the mirror artifacts as classically seen, and reverberation artifacts. Now, in few situations, there's cardiovascular collapse post extubation. So you have underlying conditions like hypovolemia. There is reduced blood volume which can lead to hypotension. So I'm sorry, here it should be post intubation and not post extubation. It has to be post intubation. Another condition is shock, when the conditions like sepsis or cardiogenic shock, hypoxemia and acidosis, which can worsen the hemodynamic instability, and of course, if there is pre existing cardiac diseases, all of which uh, can lead to cardiovascular collapse post intubation. Of course, medications, induction agents like propofol, which we discussed, or vasodilatory medications, which can lead to hypotension. Now, intubation procedure, which is a positive pressure ventilation, which can reduce the venous return and thus potentially can cause hypotension. There is also vagal stimulation, which can trigger bradycardia and again leading to hypotension. And awakening from sedation. So the patient's body may react to the intubation by causing a sudden increase in the sympathetic activity, leading to rise in the blood pressure and heart rate, which can be actually dangerous in some cases. Other factors like difficult airway, which will have a prolonged and a multiple intubation attempts, which can also increase the risk of complications. Older the patients, it may be more susceptible to cardiovascular instability. A SAPS-2 score, which is high, is also associated with increased risk. And the SAPS stands for Simple Acute Physiological Score. So, what can be the corrective measures or the measures which can mitigate this problem is the hemodynamic stabilization with a proper fluid resuscitation, and as I said, there should be a little less threshold for this patient to be started on low dose of noradrenaline. A good pre-oxygenation before intubation. Consider apneic oxygenation in the form of high flow nasal oxygen during intubation to prevent hypoxia. Now, during intubation, you can minimize the vagal stimulation by using a local anesthetic, RSI, which we discussed in detail, and of course, optimize the ventilation with appropriate setting again to prevent hypoxia or hypercapnia. Post intubation, you need to have continuous monitoring of the vital signs like heart rate, blood pressure, saturation. The vasopressor support also needs to be monitored. There should be a fluid resuscitation, treat hypoxemia and acidosis, and of course consider right ventricular dysfunction, especially in patients of ARDS with the possibility of right ventricular dysfunction, and we need to optimize the preload and afterload in these particular situations. Other strategies like intubation bundle, which we discussed, I think, in our first part of this series, needs to be implemented. Airway management algorithm, which has a clear cut plan for management of difficult airways, and it is displayed. Use of video laryngoscopes, and of course avoid neuromuscular blocking agent if possible, which can actually worsen hemodynamic instability but only in few situations. So these are the kind of protocols where you have a 6-member intubation team, you have a 5-member intubation team, or a 4-member intubation team, and this is the intubation checklist which is to be clearly kind of displayed in critical areas like emergency department, ICU, operation theater, and so on. So prepare the patient, prepare the equipments, prepare the team, and prepare for difficulty. So I think with this, I'm going to end this exhaustive series of management of the airway or difficult airway in ICU. I hope you all enjoyed it. I hope it is useful, especially for exam going students, the IDCCM, the DRNBs, and the DM critical care students. And with this, if I may request you to please like, share, and subscribe my channel. And I assure you to bring more and more interesting and educational and informative videos in my next series. Till then, goodbye. Thank you so much.